can I go straight over to Dr. Becky Cooper?
Thank you, Chair, and thanks so much for a really interesting discussion so far. I know that colleagues are going to come back to health visiting and all the excellent services that provides. I just want to pull back a bit, if that's all right, to look at how your interaction with the government is going. So the government recently published its third iteration of the Family Hub Model Framework, which I'm sure you've seen, touched upon, thought about. And looking at it, there are 3 delivery areas: access, connection and relationships, which I'm sure nobody's going to disagree with that. But I just wondered, perhaps if we go along the panel, if you could just give me a sense of how useful this framework is and perhaps what you use it for, and then we might come back to how we might improve it. So I don't know, Christine, could I just start with you?
I think I might defer to others since I know we're short on time.
Go.
I think that those key areas around access, connection and relationships are absolutely vital for us to collect data on at the moment. And we know that access is absolutely key in terms of inclusion, reducing health inequalities. Connection and relationships is something that is a real strength of, the Family Hub model, because what we're really trying to do is to enable parents to actually, develop those relationships for themselves and make them lifelong, and therefore strengthen communities. I think that there are other areas, though, that it would be really useful for us to look at in relation to the sort of data that we need to collect to really think about reducing inequalities. We know, for example, that there's been a huge increase, a 42% increase in the number of children under 4 attending emergency departments. And so thinking about, some of the health-specific data to augment that framework. We know that school readiness is a huge area. Joe, you talked about special educational needs. We know that now children are waiting over 2 years for getting a diagnosis, around that. So I think some very targeted areas in relation to the sorts of improvements that we want to see in health, in reducing health inequalities, added to that framework would be really useful.
Thank you, Oksana. Rachel, any thoughts?
Yeah, we've worked with the Family Hubs and Start for Life programme now. This is our 4th year of the programme. Really proactive and collaborative work with the Department for Education. We have a regional relationship officer. We have regular conversations. The framework, I think, as long as there is agility and flexibility within that framework, we all recognise the need for the department to actually gather information in order to convince and make the case to Whitehall for further investment. And that's basically what is the bottom line. It's the same with every programme, working with supporting families, formerly troubled families, exactly the same. So what I would like to see from government is a much more robust, longer-term funding framework, which enables us to plan ahead and enables us to recruit on a more longer-term basis, because, as Alison very much said, parents want stable relationships with their practitioners. We don't want to be chopping and changing people. We don't want people to be seeking other jobs. So that long-term funding arrangement, something that I think government has started to do this for the following local government settlement, is clump some of the grants together into one place, put some conditions around it so that it does become sensibly ring-fenced to certain things. And I think that's really where we would see a huge benefit, and maintaining that agility and flexibility, because it's not, I think Christine said, it's not an exact blueprint. None of this is an exact blueprint, because we've got to be based on local needs. Hull is very different to Devon. So what Devon will need is very different to what Hull will need. And there can be some core within that, and I think health visiting, midwifery, absolutely core to a very successful first 1,001 days. And then what we wrap around all of that needs to be based on local need. And I don't think the framework goes against any of that, and I think we work with it very proactively, but we very much are based on things that give us some flexibility to respond to local need. But I understand where they're coming from in terms of making that case in terms of longer term.
So thank you, Rachel. So just because yourself and Roxana, I think you're complementing what you're saying, but basically Roxana's saying we need some targets because we need to understand what's working and what's not, and you are saying, of course we'll do those targets, but we need some local flexibility.
Exactly.
Fine, thank you. Alison, is there anything you want to add?
Well, I would totally agree, actually. I think you summarised it really well. I think it's really important that we have a national blueprint because the key factors that affect outcomes for children don't vary that much between local authority areas. The intensity varies. So you might have a local area which has much higher level of deprivation, so you'll have more children affected, but actually vulnerable children live in every single postcode across the UK. You just have to be a health visitor for a couple of days to know. Behind a front door on a high street that you don't even know a person lives there, up a dusty farm track, there are vulnerable children in every postcode. So we need a national blueprint and high aspirations for them. I think the local flexibility comes in as in how the service is delivered, not whether you get a service or not. And actually at the moment what we're seeing is variation in whether you get a service or not. If you have a perinatal mental health problem, you should get a service regardless of where you live. If you're in Tower Hamlets, it might be slightly different if in Southampton, but you should still get a service. And I think that's where local flex comes in.
Lovely. And I wonder if I'm just going to pick up really, and I might bring Christine in around data collection. From what you're saying, and I haven't seen specifically the data that you collect, it sounds like there is more to do in order to, one, collect the right data that we need to collect, and two, to standardise the data system collections. Is that right? Does that
I can respond a little bit to that. I think we are collecting some really good data now, and I understand where the word spreadsheet sends shivers down my spine. But yes, I think we are all on electronic systems now. Okay. Unfortunately, not every local authority is on the same electronic system. We're not on the same system as our health colleagues. So there's many things around data collection that I think could be refined, definitely. And if you find the silver bullet to that one, you must share it with me. I think we do a fantastic amount of data collection, but in Hull, it's about using that data to the best effect and understanding that data, not just collecting it for collecting's sake. And often, it's not just the data; it's the qualitative work that we get, the feedback from parents, the case studies. So when I go and speak to my cabinet in Hull, very much bringing it to life with case studies, telling it how it is, because they're the people on the ground that are seeing those families in their constituencies that are experiencing the work of the family hub. So I think it's really important to hear from parents.
Thank you, Rachel. And if I just sort of move it on, so when I look at what the IFS analysis has shown, I'm looking at sort of time spent using family hub services by household income, which is great. It's not huge amounts of data, if I'm being really honest. Yep. So, Christine, could you just summarise for us what is currently known about family hubs, and then perhaps we'll have a clearer understanding of where the gaps are.
Yep. So at the national level, we have relatively little data that is currently publicly available that gives us that national picture. There is an ongoing program of evaluation, so I hope and would expect that as those results start to become ready and start to become published, we'll start to know a lot more. We know a lot more, and I think you've heard that we know a lot more within local authorities or within provider centres of what's happening, what's working. The gap really is that taking that and bringing that to the national level and understanding, and I think Rachel's point actually is really important here, not collecting data for collecting's sake, but being much more strategic about what it is that we think we need to know, both on the operational side, but also on the national evaluation side, and what is going to build towards that long term. The final point that I would make on that is the importance here of using the resource, of being smart about how we collect. So using things like administrative data sources, linking up child identifiers where we can, so that we're not asking parents and we're not asking centres to track stuff that we really should know already from hospital records, school records, whatever the case may be.
Thank you. So if I just look at sort of one particular aspect of the limited data that are available, I think it shows that more deprived families are more likely to engage with services that are targeted primarily at parents rather than children. Is that a fair representation?
So this is based on the evaluation of children's centres in England, for Sure Start, and we find more deprived families particularly take up parenting services. So those would be things like parenting programs, Triple P, Incredible Years, that kind of thing.
Okay, so with that data that seemed reasonably robust, is that filtering into how, going back to Rukhsana's point about inequalities, is that filtering into how family hubs are sort of focusing on delivering parenting support, adult support services? So going back to your point, Rachel, about not just collecting data but actually utilising it, is that actually filtering through? I don't know who, Rukhsana or Rachel, if you want to talk on that.
I think that one of the biggest gaps that we've got at the moment in relation to data is that it's not just about the data that you're collecting. It's about joining the dots between data in education, in health, in social care. And we've seen where we don't have that join up, where children and families really do fall through the cracks. And I think that that's one of the key areas that, you know, we haven't got at the moment in terms of data with that join up. And the single child identifier can certainly, you know, support that and help that in terms of that join up. And it also then means that families are not having to tell their story again and again to different people that they are seeing. And in some of our services where we've integrated that data, it has worked brilliantly. I think that there's something around data, though, which is also about you need to build trust at that local level between partners, that, you know, the data that I am collecting, if I'm sitting in the voluntary sector, is reliable data, and then build on that if you are then the midwife, the health visitor, and whoever else, the paediatrician along the line. And we've seen this work brilliantly, you know, in our solar service, which is particularly around mental health, where, you know, GPs and a whole range of professionals input into that. But it is, you need to do work at all levels in order to really make it work.
Thank you, Rukhsana. And just picking up, sorry, just carrying on with the data for a moment. Alison, you mentioned, and perhaps Rachel, you did as well, that health visiting data are held separately to perhaps the family hub data that are collected. I'm presuming that's not ideal. And I just wondered, sort of, Alison, if you had thoughts about your health visiting services and how they interact with the family hubs currently, and then perhaps Rachel vice versa.
I mean, I think what Rukhsana's talking about is kind of the holy grail, that actually the unique child identifier, where fundamentally I think there's three big things we need to measure. Did we reach all children? Did we find their need? And did we do something about it? Put in simple terms. And actually, did we reach all children is fairly straightforward, so we've got good data on that one. But actually eliciting need, come back to the point I made earlier, is quite different to ticking a box. And that, so you've got to put good data in or you get rubbish out. So you can have a beautifully filled in tick box form of a family that tells you that everything's fine, whereas actually what you need is families to tell you what's really going on and the things that really matter that are going to impact on children. So you've got to get data collection right at the front end. So you need a practitioner skill to elicit need to develop that trust. Sharing data is really important, but it's just numbers and words flying through the air. There has to be somebody at the other end who's going to interpret it and do something about it, which is why you need practitioners in real time. There isn't an AI algorithm that you can grade a family, you're a 10 out of 10 and you're a 6 out of 10. It doesn't work like that. Adverse childhood experiences, we know it's a balance of risk and resilience factors, so it will always need a human interpretation of the real context. So 3 stages: elicit, share, interpret, and do something about it. We've got to get right. In terms of GDPR, that's where the complexity comes in, because we're sharing child data as well as third-party information about the parent, because actually most child outcomes are impacted by parental factors, and that's a really crunchy piece of GDPR that always is a stumbling block, particularly for mental health services, substance misuse services. And you might have a family who's affected by domestic abuse today, and then it's on their record, and somebody's got to take it off when their circumstances change. So it's putting stuff on and taking it off that brings in layers of complexity, and we could have a whole session on GDPR and data sharing, but it's not as straightforward as it sounds.
No, fair enough. And yet, but your holy grail, I always find interesting listening about the GDPR, because there is obviously an understanding that you are care professionals, you are, you're qualified people, you're trained, you're sort of checked for various criminal offences, etc. And yet the sharing of data within different professional groups or within healthcare,
does happen in some areas.
Yes, it does happen in some areas. It's just not standardised across.
No,
the
so
country.
when I used to work in Southern Health, which is now the Big Hampshire and Isle of Wight Consortium, we had a box you could tick on the electronic record which says contains third-party information. And so if the child then asked for their records at the age of 18, you could redact that. It was quite straightforward. So it's simple ways of getting around it, but it's not ever been agreed at a national level, and I think there's definitely a piece of work that needs to be done on that, because it would make life an awful lot easier for all of us.
Yeah.
I think locally you have to have a strategic approach to data and understanding in the context of the first 1,001 days, how do we draw together all of the relevant data and information that is going to inform our response at on this particular agenda. So in Hull we have a first 1,001 days steering group, which is a strategic subgroup of the Health and Wellbeing Board and the Children's Board, and we bring data from all of our partners that collaborate and join together in that space together and help and bring it together, and we together we analyse it and say, well, what is this telling us then? So starting with the early years foundation stage data, with our midwifery data, with our health visitor data, popping it all into the pot and saying, well, what is this telling us for Hull? What does this mean? And bringing all of those professionals together to analyse it together. Think about then throwing in what are our parents telling us about the services that we're providing in Hull, which is really, top of the list in terms of importance. And then in a targeted world, we have, we have our targeted family support staff doing an early help assessment, which uses something called an outcome star, which you may have come across, which is a holistic assessment of a range of different needs, going from finance and money through to physical and mental health, through to education and safety for the child, etc. And then we can measure progress for those families in our targeted world, and we can measure the progress that we make with them by putting in that targeted team around the family and measuring the progress of that family specifically. So there's lots of things, but there's no one size fits all, I don't think, at the moment.
No, and that's what interests me, is that there's places that are absolutely excellent, and places that, frankly, with no disrespect to all the very hard-working people, aren't doing so well. And I'm like, as a national government, how do we address that? Sorry, Rukshan, did you want to come in?
I was just going to add that I think, what is also vital is that sometimes we just look at it from the lens of us as a statutory sector provider. And I mean, I'm a clinical nurse, trained by background, have spent many years in the NHS looking at data, also looking at health inequalities data. And yet, when we did our work in 3 regions across the country, and we thought we knew what data we needed to collect to improve child health equity with Sir Michael Marmot, and then we asked children, we found that the most important thing to them was actually relationships and connectedness to their local community. Now, we don't, in any of our local authority data sets or our NHS data sets, have any sort of measure around relatedness, which countries like Norway have. And actually, there's a lot that we can learn from other countries in terms of the type of data that we're collecting.
And I think there are some easy wins here as well. So one real challenge when I talk to people at Department for Education about the Opportunities Mission is they're looking at early years foundation stage at age 5, and they're saying we actually don't hold records on anything that happens to these children before that point, other than whether they take up childcare. We have health visitors who are carrying out age 2.5 checks, and that data isn't linkable at the individual child level to what we know in the education space. So there are all of these different places where the fact that services are organised within departments and data sets and data sharing is done, even at that national level, is a blocker to building up an integrated picture of children's development in those earliest years of life.
Thank you, that's really clear, and it does sound sortable, but it just sounds like it needs a bit of a spotlight on it. Thank you so much.